Yes.
Shall I try sharing one more time?
Yes, you can.
Huh? Was that okay?
Yes, it was all right, sir. But is there any audio to that?
No, no, no. No audio.
Okay, then I think it should be fine. Hello. Dr. Pujari? Hello.
Tell me,
Should I open
Maxi.
the room? I'll open the
Yeah,
room. It's
yeah, open,
8:40.
open for the house. Yeah, yeah.
Okay.
Immediately. Yeah.
Yes, yes, I have done that. Yes, I would request all faculty to mute yourself while one person is talking so that there is no disturbance.
Shall we begin, Mansi? I think we have more than 50. We're already at. So,
Yes, sir.
Mansi, let's begin. So, good evening, everybody. It's our second module on stroke. And after the first one, wherein there was a mix of a bit of basic science as well as clinical questions, today we have more clinical and management related scenarios, as you can see. And we have 4 lectures as usual. And we begin obviously with radiology before we move on to the management. And our first lecture on neuroradiology is by Dr. Banga. You've already heard him last time, so you know him very well. And with no further delay, I request him to begin his first lecture. Thank you.
Is my screen visible, Dr. Shrikar?
Your volume has to be slightly higher. That's it.
Is it better now?
Yes, yes.
Yeah.
That's
I
good.
thank you once again for giving me this opportunity. It's always a pleasure to get engaged in educational activities. So I'll discuss without any further ado. I'll go forward with my topic, which is neuroradiology for acute stroke. It's quite a vast topic, but what we would be discussing is importance of acute stroke imaging and the goals, followed by the imaging modalities in the form of CT and MRI. We'll discuss CT and MRI one after other in ischemic stroke and then subsequently in hemorrhage. Then we'll discuss about protocols which can vary amongst hospitals and a practical application of the same. So coming on to importance of acute stroke neuroradiology. Why is this so important? So it tells us about the diagnosis, whether the patient who is having symptoms of stroke, whether he actually has a stroke or he has some mimic or a chameleon. It also tells us whether the stroke is ischemic or hemorrhagic. It also tells us about the prognosis depending upon the size of the infarct. It also tells us and enables us to make treatment decisions, such as a patient who presents within a window and has ischemic stroke is eligible for IVT. But the same patient, if we know that he has a large vessel occlusion, which is a proximal one, then he is a candidate for endovascular treatment as well. The imaging also tells us about bleeding risk in patients who are undergoing IV thrombolysis. Now, these are the guidelines. AHA says that it should be performed within 20 minutes in arriving in an emergency department. But what is the ideal imaging? So to answer this question, we should know that it should be easy to use, it should be fast, the interpretation should be easy, it should be informative and should make us eligible for making treatment decisions. And but ideal imaging, ideal scenario doesn't exist. But how to decide? That there are constraints of time, there are constraints of cost, access, which can vary amongst different places. It also varies with regards to preference of treating physicians. Some people like MRI, the other are more comfortable with CT. Availability of expertise, for example, if you're doing a CT perfusion, whether you have that facility or not, whether someone is available 24/7 to do it or to read it, and then availability of endovascular therapy as well. So what are the goals? The primary goal is to distinguish hemorrhagic and ischemic stroke. And the secondary goal is to know about the location and extent of infarct as well as the clot, and to know about the salvageable tissue, and also to identify possible stroke mechanism or etiology, which can be atherosclerotic, embolic, or dissection, or anything. So this is the goal of imaging. You should know about whether there's an hemorrhage or not. You should know about salvageable tissue. You should know about a large vessel occlusion, which can be done by different mechanisms. So the imaging modalities can be a CT, a CT angio, and a CT perfusion. While in MRI, you do an MRI, a diffusion, perfusion sequence, you do MR angio, you do GRE. So what is the ultimate aim? The ultimate aim and the ultimate way that you should go about is we should know the 3 P's of imaging, which is parenchyma, pipes, and perfusion. So parenchyma tells us about the early signs of stroke. The pipes is either you do an MR angiography or CT angiography, by which you will know about the thrombus as well as the collateral status. And then comes the perfusion, which can either be done by a clinical perfusion mismatch, by a CT perfusion, or by an MR perfusion. So coming on to CT, there are certain advantages and disadvantages of every imaging modality. CT has its own. So all of us know it's widely available, cheap, easy to use. It's relatively safe. Doesn't You don't have to worry about implants, and the claustrophobia is not there. Doesn't take too much time. It's very fast, especially in those patients who come with left hemispheric stroke, having altered sensorium. It's relatively preferable and easy to do. Disadvantages, it may miss subtle features of brain pathology, especially early in the course. There are certain artifacts that can make it a bit difficult to interpret. You also are more likely to miss small infarcts, especially in posterior circulation, or if there are any lacunar infarcts. It's not as sensitive as MRI for hyperacute stroke. So, and it also involves radiation. So coming on to CT, we'll discuss every modality in three Ps, the parenchyma, pipes, and perfusion. So coming on to CT parenchyma, plain CT denotes the signs of ischemia as early as 45 minutes. We should know whether it's an hemorrhage or not, whether there's more than 1/3 of MCA hypodense infarction or not, which tells us whether to go ahead with IV thrombolysis or not. We should also get to know that there are any hyperacute stroke signs, and then we should know about aspects which tells us and guides us about treatment decision making. So what are the signs of acute stroke on CT? So what happens is, as soon as the the ischemia happens, sodium potassium ATPase starts dysfunctioning and the water starts entering, which leads to hypodensity in CT. So a 1% increase in brain water leads to further hypodensity in CT. So these are the signs such as the loss of distinction amongst different nuclei of basal ganglia, which is known as lenticular obscuration, which means the lentiform nucleus is not easily visible. Then there is insular ribbon sign, which means that the cortex, the gray and the white matter, because the gray is gray because it has less water content. As soon as the brain injury starts happening, the water starts moving inside. So the gray matter also starts becoming more hypodense. So as it increases, the differentiation between the gray and the white kind of starts going away. If it happens in insula, this is known as insular ribbon sign. If it happens over the convexities, it is known as cortical ribbon sign. And then because of edema, the sulci are not as easily visible as they are without infarct. Then the CT also tells us about aspects which we'll discuss a bit later. And there are certain signs in large vessel occlusion which can also be seen in patients by a plain CT, which is hyperdense MCA, Sylvian dot, or hyperdense basilar artery sign. So what are these? Especially in these are especially visible in thin sections, especially less than 5 mm sections, and or lower sections. And what happens is, when the blood is not passing as quickly as it should, the vessel starts becoming hyperdense. And if the same vessel, if you see, if that happens in M1, then it is known as hyperdense MCA. If it happens in M2, it's known as Sylvian dot sign. If the same thing happens in basilar artery, it is known as hyperdense basilar artery sign. So why is it the CT is so important? Because it tells us about the presence, clarity, and extent of early ischemia. It also tells us about whether to go ahead with IV thrombolysis or not, and also about the risk of hemorrhagic transformation. So these are the signs that I was discussing. The insular ribbon sign, which if you compare it from the opposite side. So one thing that is to be remembered while reporting a CT or while reading a CT is that it has to be contextual reporting. You have to compare the normal side from the abnormal side. The windowing has to be there. So all these are technical aspects which I will not go into detail with, but they are always to be kept notice for, and they should be observed. So the insular ribbon, in which the insula, if you compare the left from the right side, the insular ribbon is not as easily visible. The obscuration of lentiform nucleus, again comparison from right and left. This is hyperdense MCA sign, which can be correlated with the CT angio signifying M1 occlusion, Sylvian dot sign signifying an M2 occlusion or proximal one, and then there is sulcal effacement and loss of gray white differentiation. Now coming on to aspects. Aspects is a nominal score with a total value of 10. And there are supraganglionic, it is labeled as supraganglionic level and ganglionic level. And what is more important, that even the smaller areas such as caudate, insulin ribbon, internal capsule, and lentiform nucleus are given as much importance as the larger areas of cortex. So the zero, if what we do is for every area that becomes hypodense, we reduce 1 point. So if patient who doesn't have any infarct has an aspect of 10, and a patient who has a malignant M1 MC infarct with basal ganglia and cortex, all of that infarcted, has an aspect of 0. So the larger the aspect, the better is the prognosis. The lower the aspect, the worse is the prognosis. There are certain limitations. It fails in posterior circulation. It only limited to MCA territory. The watershed areas are not as easy, and the windowing. So you should know about stroke window. And if the patient has a lot of motion artifacts, the scan quality is not as good, then it may lead to a problem with aspects. And it needs a lot of repetition over time and a lot of learning. Coming on to CT angiography, it tells us about whether there's a large vessel occlusion. It tells us about aspects. So it has been given in many papers that CT aspects is a better way to predict about the infarct core than a plain CT. It also tells us about clot burden, the collateral score, especially the multi-phase CTA. It also tells us about the, if you want to go for an endovascular treatment in the patients who had a large vessel occlusion, it tells us about the technical success rate. It tells us about the excess, if the arteries are tortuous, and the additional information that it gives. It has a very good sensitivity, specificity. It's very fast, and it's very useful in general day-to-day practice. So coming on to multi-phase CTA, what happens is that in plain CTA, what we do is we have a single point imaging in the of the brain. But in multi-phase, we take repeat imaging at least twice after 8 and 16 seconds of the first image. So the coil moves like this, up and down, up and down, up and down. So it tells us about how the blood is entering in the parenchyma, how it is washing out. And if there is a phase delay with a late washout, then it tells us that there is a penumbra. So this is how it looks. So this is the infarct core. This artery is occluded here, for example, M1. Then there are leptomeningeal collaterals and the other collateral system which takes over, and it keeps the brain alive. It keeps providing it oxygen for some time, but only for some time. And later on, if keep if this blood vessel will remain occluded, then ultimately this core, which is a small area of infarct in the beginning, will involve the whole of the penumbra or a part of it. So we should know about CTA, the multi-phase CTA. There are 3 phases, and by multi-phase CTA there is a collateral score. There have been many collateral scores, out of which the easiest one is to label it as good or bad, depending upon whether there is confusing more than 50% or less than 50% territory. Coming on to CT perfusion, so the concept of penumbra is, so there are 3 things that we measure in CT perfusion. One is cerebral blood flow, the second is cerebral blood volume, and the third one is mean transfer time. So if the in the initial phase, when there is an ischemia, what happens is that the blood flow goes down, but the blood volume remains normal, and the mean transfer time is going to increase because the tissue is going to take more, the protons are going to take more time in washout. What happens is subsequently that with evolving time, what happens is the blood flow and the MTT, they are down, but the CBV also starts going down, which ultimately leads to infarct. So if there is CBF is equal to CBV, then the infarct is matched. If there is CBVs and CBF have a mismatch, then the patient has a penumbra. And this is how the technical aspects of it, how you go about it, and I'm not going to go into detail of these. And this is how it goes. So that the contrast, it enters in the brain, it reaches its peak, then it subsequently washes out of the brain, and this is the graph that we get. And there are a lot of technical details involved in. There are different protocols in different machines. For example, if you're using a Siemens machine or a Philips machine or a GE machine, everyone has a different CT perfusion software. There are now rapid software and other softwares coming, telling us about the tissue. So this is the same. So coming on to MRI again, it is more sensitive. We know it is the posterior fossa is better utilized. In spinal cord, it's very good, which is a pitfall of CT scan. It also can tell us about old hemorrhages, but there are more disadvantages. It is relatively expensive, not as widely available. It requires the patients to be immobile for maybe 10-15 minutes, which is a bit difficult in large vessel occlusions in acute stroke. So this is the MRI stroke protocol that's mostly widely followed. You do a diffusion weighted imaging, you do a flare imaging, susceptibility weighted imaging, an MR angiography, MR perfusion, and an arterial spin labeling. So the diffusion weighted abnormalities comes as early as 11 minutes, and they are highly sensitive and specific, while flare takes around 3 hours to pick up early ischemia. The usefulness of MRI especially is in the posterior circulation stroke where CT fails. It also is important in strokes with low NIHSS score, especially in posterior circulation. It also can sometimes make us a bit, especially in posterior circulation stroke, if you want to do an aspect, it's a better modality to do a diffusion aspect than you do a CT perfusion aspect. So coming on to each of these sequences, diffusion detects very early. It has a high sensitivity and specificity. ADC is best to detect temporal evolution because after 7 days, like it tells us if the ADC is not low anymore, it tells us that they have been already 7 to 10 days past the acute stroke. The flare develops over some time, usually we say around 3 hours. And if there is a diffusion flare mismatch, it tells us that still we have a penumbra, we have a salvageable tissue with around 62% sensitivity and 83% predictive value, which is very useful in wake-up strokes, and the wake-up trial has proved that. Then in patients who have a large vessel occlusion, the vessel sign, which is non-visibility of these vessels in flare imaging, can be found. Uh, Coming on to perfusion weighted imaging, gadolinium contrast is used. As the contrast passes through the brain, there is a signal drop which gets picked up, and which gives us estimate about the perfusion weighted imaging. Susceptibility weighted imaging is very important to know about the blood. Then it also tells us about the thrombus. So the clot which is freshly made is RBC rich, blooms in susceptibility weighted imaging. And there is also a sign known as asymmetrically prominent cortical vein sign. So what happens, because of increased deoxyhemoglobin on the site which is having low perfusion, the SWI appears, the veins in the SWI appear darker than of the normal site, and after successful reperfusion they tend to disappear. So it's a very important sign. um, uh, this is how it looks. So you can see there is a blooming in the susceptibility weighted imaging, which tells us that there is a vessel occlusion which is easily correlated with an MR angio. And this is what you know as asymmetrically hyperintense cortical vein sign. So because of increased deoxyhemoglobin, which is as a result of large vessel occlusion on the left side, the veins are hyperintense. So different sequences, how to evolve is very well written in many books, and I've given the references as well to read amongst those. I would like to discuss a bit about MR aspects. It's especially important as the CT aspects is in anterior circulation as well as in posterior circulation, but CT aspects, the sensitivity isn't as great in posterior circulation. While MR perfusion aspects has a very good diffusion aspects has a very good sensitivity. So it's the maximum score is 10, which is for 2 is for midbrain, 2 is for pons, while 1 each for thalami, occipital cortex, and for cerebellar cortex. So if the score is less than 8, that means that there are more chances of having a poor prognosis even after recanalization. So usually in most of the centers around the world, an MRI, especially a diffusion sequence, is what is mostly done, even if you have a CT perfusion mismatch before proceeding for the mechanical thrombectomy or endovascular treatment. Then there's arterial spin labeling. It's the talk of the town. It's what happens is instead of giving contrast, the protons, the blood is specially labeled to visualize and quantify the blood flow. It's especially useful in kidney diseases, and it has a little dependence upon blood-brain barrier, which is often compromised in stroke patients. And it is very promising. It's probably the future in MRI as far as the perfusion is concerned. It's a surrogate marker for perfusion. It gives us a better value. And the MRI, how it evolves. Coming on to hemorrhages, MRI is as sensitive as CT. We know CT is very sensitive. There are certain signs which come very early in CT, which are worth mentioning. The CT also tells us about hemorrhage, its location, whether it is intracerebral, whether it is epidural, extradural, subdural, intraventricular, subarachnoid. We can also estimate the volume. The popular formula ABC by 2 is there to know about the blood volume, and we know if the blood is more than 60 ml, the prognosis is poor. Then there are certain CT signs in hemorrhage. The newer ones are Plenth sign, black hole sign, island sign, and dot sign. The Plenth sign is if you have a large hemorrhage, a hemorrhage which is large, and there is an hyperdense as well as the hypodense regions. For example, a large hemorrhage having hypodense regions, then hyperdense regions. The island sign is if you have a large hemorrhage and there are small other patchy hemorrhage like these, which is not connected from the main hemorrhage. This is known as island sign. The black hole sign is a hypodense region surrounded by an hyperdense region which is not connected to the adjacent brain tissue. Then there is dot sign on CT angio, which is a serpiginous hyperintensity, which can be seen in the CT, which is a predictor of the hemorrhagic transformation and the worsening. It means that there is an active bleeding going on, and it's been proven in multiple papers that it holds its own value. Now, coming on to protocols, every hospital has its own. I've been very lucky to work in many setups. There were some of them had a CT-based protocol or an MRI-based protocol. But what do we initially essentially need is a CT angio, and a CT perfusion, or you need an MR diffusion along with an MR flare and an MR angio. So you either go by a diffusion clinical mismatch, or you go by a CT perfusion mismatch and a large vessel occlusion depending upon CT and MRI, and decide about the treatment. And so if there is you do a CT or an MR, you know if there is an hemorrhage, then you proceed for IVTP and then the endovascular treatment. So there are certain practical applications. For example, I'll discuss these two slides. If the patient has a large vessel occlusion, if you see the diffusion is already not very good, you know that the penumbra is small and the patient is gonna do bad, so you're not gonna intervene. Vis-a-vis, if the patient has a large vessel occlusion and thus there are small diffusion restrictions, so means the infarct core is small, you have a lot to save, the penumbra is high, and if you don't intervene, then the patient has a large infarct. If you intervene, the patient may have been prevented from having this. So to summarize, this is the basic summary of what I have spoken. So you can know about core and the penumbra clinically by an NIH stroke severity scale, or by doing an plain CT aspect, CT angio aspects, or an MR diffusion. Then MR perfusion, CT perfusion, diffusion weighted imaging is known as for use for penumbra. Then you should know about large vessel occlusion, which can be done by a CT angio or an MR angio. Then depending upon how your results are, you may proceed ahead and do with endovascular treatment or conservative management or IV thrombolysis, whatever is feasible for that particular patient. And this is the whole goal of the imaging, to diagnose, to prognosticate, and to tell us about etiology. Thank you very much. So I would like to acknowledge Dr. Anshu Mahajan, who has been a very kind senior to me, and Dr. Sriram Vardarajan. There are slides in this presentation which have been given by them very kindly to me. And I would like you to read the Continuum Stroke Volume 26. Dr. Menon has given a very nice summary of acute stroke imaging, mainly the CT. You should definitely go for that. Thank you very much.
As everybody has heard, see, this is as thorough as we could have got, covering each and every point related to CT and all aspects, and its MRI as well. And then last few slides, as you can see, protocols and real life examples as to how mismatch is so important to decide outcomes and prognosis. So now from diagnostic lecture on diagnosis, we would now move on to the two most important lectures on management, of which the first one is medical management, delivered by Dr. Vivek Nambiar, who is an interventional stroke specialist and neurologist at Amrita Kochi. I hand over the session to him. Vivek.
Am I audible? Sripath, I am audible?
Yes. Yes.
A very good evening to all. And first of all, thank Fine Forum for this opportunity. So we will go to the overview of the topic. So medical management of stroke includes the pre-hospital management, emergency treatment, including the revascularization, and immediate post-stroke management, management of medical complications, and long-term stroke prevention. And all these are equally paramount importance. So the one core principle we have to remember during the stroke management is the time factor. So this is a very always talked about slide. Time is brain quantified. So every minute lost is about 1.9 million neurons, and there are so many other aspects of accelerated aging due to a stroke. So here, so if there is a if there is some delay in, this is a patient with the left MCA occlusion and the reperfusion was slightly delayed, you can see that infarct has completely evolved even after reperfusion. So basically, so the issue is the time lost is brain lost, and this should be the principle. I'm stressing this because all aspects of the management, medical management or intervention management should be based on this principle. So that is why we concentrate on public education about the symptoms of stroke, so that we will save time there. So stroke pathway activation by the pre-hospital team, and the immediate assessment and transportation and first diagnosis of strokes. All these things are important because an EMS team will rule out the stroke mimics in the community by detecting hypoglycemia. And all those things can happen at the society level, because the time is brain principle would be implemented only when, when the society is more aware of the stroke and its symptoms. So the EMS team, trained EMS team and ambulance services can also give certain medications like anti-seizure medications and antiarrhythmics, and some of the resuscitation procedures can be done there. So we have the pre-hospital management protocols like field assessment of stroke by them to identify the stroke and the different scoring systems. And also we have pre-notification systems to reduce the time delay in delivering treatment, because in the hospital, if the patient is the information about the patient with acute stroke is already reached, it will be easier for the team to get active in an activated state, so that the cath lab, CT, everything can be spared, and we can give a much better door to needle time for this patient. So these are all proved by different studies. So once a patient reaches emergency, we have code stroke activation. So that is a simple measure to actually to reduce the time interval between communication between different members of the team. So common activation of the whole team by a single message. The message will go to the cath lab team, to the emergency team, radiologist or neurologist and neurointerventionist, everybody. So after reaching the emergency, we won't spare much time. So there will be ABC checking, and we will give oxygen only if it is less than 94% saturation. Otherwise, oxygenation is not necessary. And suspected air embolism, there will be oxygenation will be continued, and also HBOT will be beneficial. So we would do minimum investigations like ECG and troponin, and we shall not wait for troponin result. We just take the sample and take the patient to CT. So acute stroke imaging protocols, Vineet has given a very beautiful description of how to do it and how to go at it. As he has mentioned, it will be institution depending upon the facility of the institution, could be MRI or CT based systems. So whatever imaging system, we would go to with the principle of time is brain, because if MRI is available, we go for MRI, CT is available, we go for CT, and plan further imaging. And as per, if we look into the quality control measures, acute imaging should be done less than 20 minutes from the arrival of the patients in at least more than 50% of the patients within the window for thrombolysis. So revascularization procedures, intravenous thrombolysis with or without endovascular thrombectomy will be planned according to the information in the initial imaging. So we will try to reduce the door to needle time in less than 60 minutes in more than 50% of the patients. That is the recommendation for quality of the acute stroke care. So we have to remember the principle is always time is brain. So if we had a patient with acute stroke within window of thrombolysis, we are carrying out the CT within 50 minutes. So if there is no bleed or there is no, these are the absolute contraindications of thrombolysis. If there is a bleed, we will not thrombolyze. And if you see a large evolved infarct, subacute infarct, we may not thrombolyze. And no coagulopathy or no major surgery where there was like a laparotomy and other major surgeries. Because even though there is a large list of indications and contraindications for thrombolysis, we will look into these simple, early, very simple contraindications for doing the emergency care. So one thing we have to remember, early CT changes like hypoattenuation is not a contraindication for IV thrombolysis to begin with, because there will be certain amount of hypoperfusion or increased blood volume in those areas of occlusion, and we will not totally exclude them from thrombolysis. So CTA and CT angiogram will be helpful for identifying the LVO. So we have to remember indication is the potentially disabling deficit within an NHS score limit of 4 or more. And we have the time window for 4.5 hours, and blood pressure should be less than 185, 110 prior to the thrombolysis. So we have alteplase or tenetiplase. So we would use usually 0.9 milligram per kilogram body weight as 10 milligram bolus and infusion, and low dose also practiced in certain risk population like 0.6 milligram per kilogram. And there are trials recently coming up with the advantage and disadvantage of this low dose thrombolysis. So we have the new agent tenecteplase, 0.4 milligram per kilogram bolus, eligible for those patients without LVO. So we have a good description of penumbra and core by Vineet here. So it was the only thing is we will classify them into less than 4.5 hours, more than 4.5 hours, because less than 4.5 hours is a very golden period, and we need to move very fast for. We have to move very fast for everything, but we'll go for plain CT, and we plan for IV thrombolysis and go for vascular imaging, or we will do simultaneous imaging and identify them, and proximal MCA or distal carotid occlusion or basilar occlusion, we go for thrombectomy. So in the extended window period, like more than 4.5 hours, we will get into multimodal imaging, which has been already described. So, and we'll decide the eligibility for thrombectomy. So we will not try for multimodal imaging, like especially in very early cases. We will try only for those patients who are not beyond the window of thrombolysis. So multimodal imaging has been well elucidated by Dr. Vineet. So among the agents, we have to TPA and the TNK. So the basic thrombolytic agent is TPA. We know we have low dose and high dose. We have mentioned issues are with angioedema and less fibrin specific, and it is started up to 4.5 hours. It is given up to 4.5 hours after the CAS2 trial. So TNK is a modified version of genetically modified version of TPA, and it can be given as a bolus injection, which is very advantageous to our population because many of them are coming in very late and borderline windows. So it will be a great advantage for us. And the equal and non-inferior recanalization in vessel occlusions has been noticed in trials. There are multiple trials of TNK, and there is an ongoing trial in Canada, which is about planning to enroll about 1,800 patients with tenecteplase compared to alteplase, and that will probably be the concluding trial, which will result in the benefit of TNK over TPA or vice versa, according to the trial results. So now after the thrombolysis, we have the several issues like BP control. So the thrombolytic post-thrombolysis, the blood pressure control measures, the values for blood pressure control has been increased to less than 180 over 105 from the last guideline. So even though we used to keep a better blood pressure control, but the current guideline is sticking to less than 180 over 105. And we are not supposed to aggressively treat unless it is going 180 or 105. But generally, when in our practice, we would be a little bit nervous when we see high blood pressure after thrombolysis in Asian population. So we have to use intravenous labetalol and IV hydrolazine alternatively to keep the heart rate 50 to 60, because labetalol causes bradycardia, and IV hydrolazine is a vasodilator or arteriodilator and can cause tachycardia. So basically, if there is a bradycardia, we use hydrolazine more, and tachycardia, we use labetalol, so that we'll keep an optimum heart rate of 50 to 60. So the hydration and blood sugar control are important. Like the ideal blood sugar to be maintained in the post-thrombolytic or immediate post-stroke period is mentioned to be 140 to 180 milligram per deciliter. So there is no benefit for intense blood sugar control, and as well as there are harms of uncontrolled hyperglycemia. There is no need of a prophylactic anti-seizure medication, but seizure control with AED will be done if there are symptomatic seizures. So anti-edema measures may be instituted in very large infarctions where we don't expect we expect some amount of possibility of herniation, and we will constantly monitor the NIHS score. So urgent CT if there is a deterioration in the NIHS score, and the correction of coagulopathy if there is a bleed, and decompression in selected cases. So if the patient is not deteriorating, post 24 hours we have a CT to initiate antiplatelet therapy. And sometimes a repeat CT will show petechial hemorrhages, which are not contraindication for starting an antiplatelet therapy. So once the patient is admitted, so the major other issues will start with the patients, those patients who had significant deficits and disability, like the dysphagia. So we have to do swallow assessment and dysphagia screening, bedside tools, and some patients with persistent dysphagia, we may have to go for VFS, video fluoroscopy, and flexible endoscopic testing. So we have to go and treat the medical complications like aspiration pneumonia, metabolic corrections by monitoring and correcting the in the correct time window. And probably some of them will go for seizures and status epilepticus. And other thing is most important, the stroke unit care is the nursing care for prevention of bed sores. So DVT prophylaxis is another major aspect of medical management, like we in patient with less than grade 3 or grade 2 power. So low molecular heparin and pneumatic compression stockings are now used, but no elastic stockings are recommended for DVT prophylaxis. So and during the same time, we have to also look for stroke prevention by identifying the mechanism of stroke. So basic cardiac workup, blood workup, like all the risk factors would be investigated. But when there is a young stroke, we may have to go with a detailed workup with the ANA profile, antiphospholipid, cryoglobulins, ANCA, sickling test, serology, and some other young stroke with migraine and or some other no other etiologies. We will also go for a detection of an atrial septal defect or any PFO. So we go for TE. And some people with a neuropathy and family history, we have to look for Fabry's disease also. So there will be special situations where, like pregnancy, thrombolysis, medical management of acute ischemic stroke will be challenging, but pregnancy is not a contraindication for thrombolysis. So anticoagulated patients we would see often, especially with the newer oral anticoagulant or vitamin K antagonist. So vitamin K antagonist, we have 1.7 INR as a limit for thrombolysis. NOACs, actually, we will go for direct mechanical thrombectomy. So infective endocarditis, if it is a non-diagnosis of infective endocarditis, it is better not to thrombolyze. So dissections, suspected arterial dissections, actually thrombolysis can be done, but we would try to avoid if there is an intracranial dissection, which is well proven. But most of the time, we may not be able to identify them. So microbleeds are not a major concern. More than 10 microbleeds may be related to contraindication. And unruptured aneurysms of less than 10 millimeter size, we would thrombolyze them because they are not creating much problem. And giant aneurysm, if there is in the CT angiogram, we may not thrombolyze, and we are not sure about the safety of thrombolysis. Systemic malignancy, it's not a contraindication for thrombolysis. We have to go ahead and thrombolyze the patient in a disabling stroke. So large MCA and cerebellar infarcts are always a challenge because MCA infarct, so we do not have clear-cut early prediction which patients will undergo herniation. So that's a headache when we manage acute stroke in the unit. So we would start early anti-edema measures of 3% saline, hypertonic saline, and mannitol will be used for the initial push. And it is well proved that in randomized controlled trials that large bone flap removal with the duroplasty is very effective in all the randomized trials of decompression, especially in less than 60 years. That reduces the mortality about 50%, and in 1 year disability of 55%. But if it is more than 60 years, when we try for decompression, the mortality benefits are there, but the moderate disability is severe. So basically, old age, we would discuss with the family regarding the deficits and the disability. So in cerebellar infarction, the unexpected herniation is common, and so medical therapy largely ineffective. So we have to go for post-effusive decompression. So upward herniation is possible in case of cerebellar infarct. So now we'll go just look into the anticoagulation and the stroke prevention measures. After this initial treatment of the stroke, we have to look for the etiology, and we'll go for anticoagulation for all the atrial fibrillation patients. And the starting of the anticoagulation is a challenge. Like we would usually start in moderate strokes 4 days to 14 days after the stroke, related to the size of the infarct. If the massive infarct and all, we would definitely wait for 2 weeks or more. But mild to moderate infarct, we will start 3 to 4 days after the stroke. So then comes about the dual antiplatelet therapy. We know that the CHANCE trial of which reveals that early 3 weeks antiplatelet therapy is beneficial in minor stroke and TIA. And long term, we would definitely stick on to single antiplatelet therapy. So if we are to anticoagulate for an LV thrombus, it is about 6 months. And if the ejection fraction is less than 45, we'll consider anticoagulation for 3 to 6 months. So lifelong anticoagulation is only for the atrial fibrillation and with a stroke or TIA. So dyslipidemia would be treated with the goal of 50% reduction in the LDL. And if there is a contraindication, if the patient were a contraindication or experience side effect with high density statin therapy, so we would reduce the LDL goal to 30 to 49%, and ezetimibe may be added in those situations. And also in those patients who had maximum dose of the statins, still there is a high LDL, we may go for PCSK9 inhibitors. So whether single antiplatelet or double antiplatelet. So one principle you have to remember is during the stroke or in stroke as the pathophysiologically, the mechanisms are different compared to coronary artery disease. They are not analogous. So double antiplatelet therapy was always beneficial in CAD, coronary artery disease, but not in stroke. So however, we have the evidence of the CHANCE trial, which is a combined aspirin and clopidogrel, proved to be superior to aspirin alone in preventing recurrent stroke by 90 days in Chinese patients with minor stroke or TIA, when randomly assigned within 24 hours of onset and given for 21 days. So this is the trial where 21 days of double antiplatelet therapy showed benefits at 90 days. So this gives us some proof or evidence for starting double antiplatelet therapy in minor stroke or TIA. But look at the POINT trial, that's a high-risk TIA or minor stroke. 90 days they have given double antiplatelet therapy versus aspirin, but it was found there is more hemorrhage compared to the aspirin therapy. So that is the duration of the double antiplatelet therapy increases, the benefit will decrease. The shortest duration of double antiplatelet therapy is useful as the 90% recurrence of these events, like recurrent TIA stroke, will happen less than 1 week. So this is a Thales trial. It is a triple therapy trial, and it was there is significant bleed and stopped. So we have evidence. If you look at the evidence-based management for acute ischemic stroke, we have thrombolysis within 4.5 hours, thrombectomy within 6 hours in large vessel occlusions, and in selected cases where there is a good penumbra, as Dr. Vineet was talking about, good penumbra, there can be recanalization up to 24 hours. And then stroke unit treatment and decompressive craniotomy for malignant infarction. So whether aspirin or newer oral anticoagulant for ESUS. ESUS is embolic stroke of unknown source. So there were several trials, because ESUS may be a short note or it may be asked as a different question. ESUS actually cryptogenic stroke without any, it seems to be embolic stroke, but we don't have a source. In those situations, there are trials where newer oral anticoagulants were considered because they have less chance of bleeding. That is the RESPECT ESUS trial, where the ESUS strokes were given dabigatran versus aspirin alone. That was a negative trial with more bleeding and no benefit. And similarly, the rivaroxaban given compared to aspirin in ESUS trial was a negative trial. There is one more trial, Atticus trial, is, I think the results are awaited, where apixaban is given compared to aspirin in the ischemic stroke of unknown, embolic stroke of unknown source. So overall evidence suggests not favoring anticoagulation for ESUS as per even the NOACs. So no, it is the time duration, the time period is for NOACs. Like we are day by day our prescription of newer oral anticoagulants is increasing. So we have dabigatran, rivaroxaban, apixaban, and edoxaban. We have different trials: Relate trial, Rocket AF trial, Aristotle, and Engage AF trial. And basically they are all comparing with the existing therapy of warfarin to others. So and looking at whether they are non-inferior or superior, and followed by superiority. So most of the designs are non-inferiority, and these are the results. We can see that the dabigatran, all the neuron oral anticoagulants, most of them, especially dabigatran, has got they have got better side effect profile, as we know. Like the major clinical bleeding risk is the, look at the relative risk is 0.93 compared to, that is less than warfarin. That is for Rocket AF and rivaroxaban. That is not very beneficial compared to major clinical bleeding. And Aristotle is for apixaban, we can see 0.69, the less number of bleeds, major clinical bleeding, including intracranial bleeding. And we know that during this period of follow-up of 1.9 years, around 1.9 years to 2.8 years, the primary outcome is less. The hazards ratio HR for the primary outcome, that is a stroke or combined ischemic events, is less in all these newer agents. But there is significant reduced risk of bleeding in case of apixaban and dabigatran and edoxaban, but that is not very significant with the rivaroxaban. But however, the hazard ratio for developing ischemic event is less with rivaroxaban, and also with others. So these all agents are going to change our prescription pattern in the coming years, because as time goes, insurance coverage and cost may not be a problem in the coming years. So these are just thanks to Dr. Pujari for the slide. So the risk of stroke in different medical conditions and valvular conditions, atrial fibrillation, 0.5 to 7.6% per year, anticoagulation. So these are different different situations where we have atrial fibrillation or risk of cardioembolic stroke and their treatment. So rehabilitation after stroke is a challenge. We have less number of rehabilitation specialists. So there were several trials tried in rehabilitation, early aggressive mobilization with the physical therapy versus usual therapy. That is our trial. That was a negative trial. Then we have one trial which is conducted in India by Dr. Jayaraj Pandian. That is a very, very important trial, because for our country, that is an Acute trial where family member-led rehabilitation protocols done at the home by training one of the family member versus conventional therapy, including physiotherapist. But this was a sort of positive trial, because the family member-led therapy was non-inferior to physiotherapy as per the trial which was published in Lancet. So we have virtual rehabilitation, telemedicine, and versus conventional therapy trials which are going on, as well as there are trials going on in the area of speech therapy for delivering speech therapy through the app. So many apps are being developed. So, and many of them are under trials. So in conclusion, medical management of stroke is time sensitive, time intensive, and multidisciplinary and comprehensive. All aspects to be given due importance, and stroke units are the best place for instituting these therapies. And acute revascularization therapies are medical and EVT. Lysis can be done up to 4.5 hours, and in more selected cases with a good penumbra. In all steps, the principle of management is time is brain. Thank you.
Again, Dr. Nambiar, thank you. Very thorough it was. As you all should notice, it starts right from triage, stroke code activation, revascularization, secondary prevention, general care, and rehabilitation. So this answer may sound a bit easy that you've done every day, but it has to cover and include all the points that were just discussed. With that, now we'll move on to another very important aspect, which is obviously the intervention and its recent advances, which will be covered by Dr. Oak, who is our young dynamic intervention neurologist in Mumbai, Western Mumbai. So off to him. Just before that, before he begins, to remind you of our Thursday clinics, and this time it is on bedside clinical evaluation by Dr. Rakesh Singh. And with that, I hand over the session to Dr. Oak.
Yeah, hi, good evening, everyone.
Good evening.
So time is brain, and we are definitely running behind the time as far as this webinar is concerned. So I'll run through few important slides. Now, not many of the residents have exposure to cath lab. So I'll give you some basic information about mechanical thrombectomies and why it's important. Because it's a rapid, safe, and effective arterial recanalization to restore the blood flow remains the primary goal of hyperacute ischemic stroke management. So everything depends upon how fast you recanalize the vessel, whether you do it with IV TPA or whether you do with mechanical thrombectomy. The fast recanalization is the most important thing. And benefit of IV TPA in large artery occlusion is very limited. Early recanalization is generally less than 30% in carotid, MCA, and basilar artery. So large vessel occlusions, only 30% of the patients will have early recanalization. And good clinical outcome is only seen in 25% of the patients. So it's very important to open the vessel. And we know that most of the times IVTPA is going to fail to do that. And that's where the role of mechanical thrombectomy comes in. Initial few trials were failures up to IMS3. The trials failed, and then the study design was criticized, and then there were few important trials, the 7 important trials, 9 important trials in fact, they were published, and all of them showed that mechanical thrombectomy works. So why we should do mechanical thrombectomy? Because the efficacy is shown beyond doubt, and only challenge is when we should do it and how we should do it. As Dr. Banga showed, that if there is infarct is significantly big, then probably mechanical thrombectomy is not going to work. So these are the current guidelines that how and when we should do mechanical thrombectomies. So first important thing is that when you are doing bridging, if you're giving IV TPA, then you should not wait to see if the IV TPA is working. Now that is what is done in cardiac patients. In MI, they wait for some time before they take the patient on table, and they call it as rescue recanalization. Whereas in neurology, in acute stroke patients, once you give IV TPA, you have to ship the patient for mechanical thrombectomy if the patient is eligible for the same. We can't be waiting if the vessel recanalizes with IV TPA. Then patients should receive mechanical thrombectomy with a stent retriever if they meet following criteria. That is, pre-stroke MRS score should be 0 to 1, causative occlusion of the ICA or MCA, age more than 18 years, NIH score more than 6, aspects more than 6, so favorable MRI, and treatment can be initiated within 6 hours of symptom onset. Then all the benefits are uncertain. The use of mechanical thrombectomy with stent retriever can be done within 6 hours of symptom onset if patient has M2 or sometimes M3 occlusion. Sometimes M2 or M3 occlusion on the left side can present like M1 occlusion. So they should be treated as large artery occlusions and can be treated with mechanical thrombectomy. And even for anterior cerebral arteries, vertebral arteries, basilar arteries, even for PCO occlusions, we should consider mechanical thrombectomy, though the evidence is not very strong. And after the DAWN and DIFFUSE trial, we know that we can do up to 24 hours, we can do these mechanical thrombectomies in LVOs with clinical diffusion mismatch or a significant penumbra as demonstrated by perfusion imaging or ASL imaging. Now, when to do the practical considerations of mechanical thrombectomy, we should have a documented large vessel occlusion up to 6 hours and a few selected patients up to 24 hours. Lack of extensive early ischemic change, that is, infarct volume should be less than 100 ml. Significant clinical deficit at the time of treatment, that is, NIH should be more than 5, or a low score that is functionally significant for the patient. There should be significant diffusion perfusion mismatch, and patient should have a good collateral circulation, which will reflect in a good penumbra. So what I do in my hospital, we are basically a MRI-based protocol, and we do MRI in 11 minutes, and we are using ASL as a technique to demonstrate significant amount of penumbra, that is non-contrast perfusion. So this is a patient, this patient who has a bad NIHS with this kind of scan is a typical patient where I'll expect that this patient will do well after doing mechanical thrombectomy. Because this is a diffusion image which is showing a small core and a significantly huge penumbra. This is the ASL mismatch. You can see that the perfused brain and this is the hypoperfused brain showing a big mismatch. And on a SWAN image, you can see that there is a thrombus into the proximal MCA, and you can see that it's complete cutoff in the MR angio. So after recanalization, you can see that there is no thrombus on SWAN image into the MCA. It is completely open. There is good filling of the vessels of the left MCA, and there is complete reversal of the penumbra. So this patient will do excellently well, and he will walk back home. This is another patient where you can see a small infarct here and huge penumbra. Again, this is MCA occlusion, and post recanalization you can see the infarct has not increased in volume. There is complete recanalization of the vessel, and there is complete reversal of the penumbra. So we have now numerous cases, hundreds of thrombectomies we have done when the scan is favorable. It's not that we always succeed in opening the vessel or we don't land up with complications, but most of the patients have remarkable recovery. Now, how we do it? What are the devices and what techniques we use to do mechanical thrombectomy? So there are two stents which we use. One is solitaire FR and Trevo. I generally use Trevo with XC27 microcatheter. Then there is aspiration catheter, that is penumbra, and there is a new stent retriever called as Tiger Retriever. I have never used it as yet. So we stick basically to either stent retriever, that is Trevo or solitaire, or aspiration technique, that is penumbra. And then we use supplementary devices, that is suction pump when we use the aspiration catheters, and balloon guide catheters when we do stent retriever technique. Then whether we should do the procedure under general anesthesia or we should do a awake thrombectomy. Now, when a patient has a left MCA infarct, these patients are generally irritable. They are not cooperative. So in such patients, we induce anesthesia. But if a patient is cooperative, then we start the procedure under local anesthesia and keep anesthetics as standby. But if it is dominant IC and MCA, as I told before, we prefer general anesthesia. It's always done via femoral approach. In my center, we use either 8F or 9F balloon guide for the ICA and 6F guide for the vertebral artery. Then microcatheter over microwire, and we navigate through the clot, and then we put the stent retriever, that is solitaire FR or Trevo stent, and then we deploy across the clot. We wait for 4 minutes so that the stent expands and holds the clot, and with balloon inflation in the guide catheter, we retrieve the stent via negative suction from the side port of the Y connector. So I'll show you how we do it. Now, another increasingly popular approach is to suck the clot. Or sometimes we use both the techniques. That is, we suck the clot as well as we put the stent into the clot as well, and we do it together. So that is called a Solumbra technique. So what generally we prefer to do is that we proceed with local anesthesia and GA as a standby, and dominant ICA, MCA preferably under GA. For anterior circulation, we use either 8F or 9F balloon guide, and I use Trevo X 6x25 mm stent for anterior circulation, whereas for posterior circulation, I use Neuron Max guide, and that is the guide catheter and ACE suction. I generally don't use a stent retriever for posterior circulation. So I'll just show you animation film as to how we do it. Now you can see that this is the clot which is migrating from the carotid, and it gets stuck into the MCA just before the bifurcation. So basically we take, this is the stent retriever. You can say this is Trevo 6x25, and these are the strut design which actually gets stuck into the clot once we deploy it into the clot, into the thrombus. So basically, along with the microcatheter, we cross the thrombus over the wire, microwire. We remove the microwire and we deploy the stent into the thrombus. So this is how Trevo is deployed. So once we deploy, it is a self-expandable stent. So it will gradually expand into the thrombus, and it will hold the thrombus into the stent. So this is how it expands into the clot, and it will hold the clot. So once it holds the clot, we usually wait for 3 to 4 minutes, which will re-establish the flow into the artery, and the clot is held into the struts of the thrombus. So this is a balloon guide catheter. So we inflate the balloon so that there is no antegrade flow of blood. So when we are taking the stent out along with the thrombus, since there is no antegrade flow into the carotid, the clot doesn't move and go into the other artery. So there is no distal embolization of the clot because there is balloon inflation into the guide catheter, and the clot completely is removed. Now another technique is we use a suction catheter. So basically we take a guide catheter, and so this is how we take the suction catheter over a smaller catheter which is called as 3 max, and the suction catheter is 5 max, which is a big bore catheter, and then we reach up to the proximal end of the clot. So this is a thrombus, and over a smaller catheter, we take the bigger suction catheter and we keep it at the proximal end of the thrombus. So basically, we are not crossing the thrombus with the bigger catheter. So this is the bigger catheter which comes, and it is at the proximal end of the thrombus. Then we remove the smaller catheter and with the wire, and we start doing the suction along with the suction pump which comes with it. So this is how the aspiration tubing is connected to the suction catheter, and then we connect it to the suction pump. And typically for 90 seconds, we perform the suction along with the suction pump, and the clot gets sucked into the suction catheter. So this is how it is done, and you can see that initially the flow is not very good because the clot is getting sucked. Once the clot is sucked, you can see a good flow coming through the microcatheter. So that means that the clot is being sucked properly. So I'll show you a case where we have done both the procedures together so that you will understand how we do it. Now, she was a 60-year-old lady, and she was a known case of rheumatic heart disease and atrial fibrillation. She was on warfarin, but because of the lockdown, she did not follow up with the doctors, and probably she did not take the medicines properly. And she presented with right side hemiplegia, with global aphasia, altered sensorium. She was intubated in a peripheral center, and her INR was 1.2. However, she did not receive IV thrombolysis, and she was sent to us for mechanical thrombectomy. So you can see she had a complete ICA occlusion. There was no flow. So basically we started with suction because ICA is a big size artery. So you can't put a stent retriever here and take the clot out. So we started with suction, and you can see that this is the guide catheter. It was a 9F guide catheter. And you can see that this is the suction catheter, which is into the proximal part of the MCA. So after the suction into the proximal part of the MCA, there was complete recanalization of the MCA. However, the clot migrated into the anterior cerebral artery. Now, the suction catheter is a little bigger in size. So 5 max or S68 will not take this curve and will not take this size of the artery. So we have to use stent retriever. So under roadmap, so you can see that under roadmap, we take the microcatheter along with over the wire. This is a micro wire which is entering into the right, into the anterior cerebral artery, and over the wire, we take the microcatheter. So once the microcatheter, so this is how we take the microcatheter over the wire. You can see that the wire is going to the anterior cerebral artery. And once we have crossed the clot, now here is the thrombus into the ACA. So once we have crossed the thrombus, we take a shoe to see that we are in the normal segment of the artery. So once we are here, we start deploying the stent into the thrombus. So this is how the stent is deployed. Now I have used 625 stent into the ACA as well. Now you can see that the stent is being deployed here, and then we retrieve the stent. You can see that the stent is being retrieved, and the balloon is inflated into the carotid artery, proximal petrous. So this stent is retrieved under the balloon inflation, stopping the antegrade flow, and you can see that there is a complete recanalization of the ACA, MCA, and there is no thrombus. This is what we call as a TK3. The huge amount of clot would be removed, but there was complete recanalization of the ICA, MCA, and ACA. So this is the post procedure shoot of the ICA. You can see that the arteries are clean, so it's clearly a cardioembolic stroke. And this was the post procedure CT. This wasn't immediately. This is what I want to tell you, that this patient to start with had a small infarct in the basal ganglia, and this is not blood. This is a dye extravasation because of the infarct. There is some leak into the blood-brain barrier. So this is not a scary scan. This means that we have opened the artery well, and this is a dye extravasation. This is a follow-up scan. You can see that the hyperdensity is disappearing. Again, this is the first scan, immediate post-procedure, and this is a follow-up scan. This patient we discharged today, and she has done excellently well. She's walking independently with little aphasia. Otherwise, she's fine. This is another patient where he was a 65-year-old gentleman with no comorbidity, and he had weakness of the left upper limb. His NHS was around 3 to 4, and this was the scan. You can see that there is a small infarct, whereas there is a huge mismatch. And this was again a swan image where you can see that there is a small thrombus over here, and and there is a distal M2 occlusion. So this patient has. We have done a mechanical thrombectomy again, and you can see that this is a 625 Trevo stent which is into the MCA, And this is the MCA which is occluded here because of the thrombus. Again, a cardioembolic stroke. And this is how we retrieve the thrombus. So this is how we deploy the stent into the thrombus before. This is the microcatheter and this is the stent being deployed. So this is the stent into the thrombus. We typically wait for 2 to 3 minutes and then we retrieve the stent under balloon inflation in the guide catheter. You can see this is the pre where M2 was not seen, whereas this is post where there is a complete regeneration of the MCA. This patient had a full recovery. You can see again ASL, this was the pre ASL, there is a significant penumbra mismatch and there is complete reversal of the penumbra. There are two more cases which I'll show you before handing it over to the next speaker. Now, this lady was a 70-year-old lady with no comorbidity, and she had episodes of intermittent weakness on the left side. So she basically was having TIAs, but on the day of presentation to the hospital, she had permanent left side weakness, and she was altered when she came to us. So this is how she was. She has typical features of MCA stroke. She had neglect, not able to see on the left side, and there was no power on the left upper limb and lower limb. So again, she had a huge penumbra, big mismatch, and watershed infarcts into the AC-MCA, and this was the angio. You can't. There was complete cutoff at the ICA. So this was probably acute on chronic occlusion. She had TIA, so she had probably critical narrowing of the ICA, and on the day of presentation, she had complete occlusion. Now, if you see the scan, if you see the circle of Willis, you can see that there is a flow into the carotid as well as ACA and MCA. This is a collateral circulation, but it was not adequate, and that's why she was having features suggestive of significant weakness or right MCA infarct. So this was the DSA shoot. I just passed a wire and did a simple balloon angioplasty, and you can see that the vessel was open. So there was a small thrombus. The thrombus load was less, and then I have deployed a stent at the ICA, and you can see that there is a complete decanalization of the vessel. So this was a stent. It was acute on chronic occlusion. So it's not always a thrombus which needs a stent retriever or a thrombosuction. This was a post scan. You can see that the infarct hasn't increased much in size, and there is complete reversal of the penumbra. This was pre and this was post-procedure scan, and this was when she came for the follow-up. So you can see how she has become post-procedure. So it's not always you need a stent retriever or suction to remove the thrombus, but sometimes it's a tiny thrombus which requires suction and angioplasty as well to open the vessel. Now, this gentleman had all the risk factors. He was on dual antiplatelets, and he developed acute onset weakness of right upper and lower limb, inability to speak. And he recovered completely. He was actually a doctor's uncle, and he recovered completely. So probably he had a TIA, and he came with NIHs of 0 into accident and emergency. So we did an MRI. MRI was normal. There was no diffusion abnormality at all. This was the MRI. There was no abnormality. But I thought we should do an angio and see, and you can see that there is a cutoff into the MCA. So this patient had TIA. So we were contemplating what we should do, whether we should monitor or we should start with IV TPA. You can see that there is a thrombus into the MCA. There is a filling defect into the MCA. And in the ICU, he developed weakness again and he became grade 0. So again, this is the MRI. You can see that there is a thrombus into the MCA. And I started bridging. I started on IV TPA, and then I took him on in the DSA in the cath lab for the DSA, and there was complete cutoff. After 2 passes, I could open the vessel, but he has an intracranial stenosis. So this patient, after the procedure, I had to put a stent. So I put a coronary stent into the MCA, and this was how it was after putting the MCA. There is regeneration of the artery. And you can see in the MRI, you can see that the stent artifact. So this patient also had done well. He had few cortical infarcts, but he also completely recovered. Now, probably this is the last case. He's a 63-year-old gentleman, and he came within golden hour with left hemiplegia, aphasia, and NIHs was significantly high. And he was definitely in the golden hour. And this is how he was. He could hold his right upper limb, left upper limb and lower limb, whereas he was. Now, if you look at it, for a left MCA infarct, he was not very bad. He was cooperative. He did not have any gaze deviation. He definitely had a bad power in the legs, but he was not how we see a left MCA infarct. Irritable, altered, not cooperative. And this was his infarct. He has a big infarct. His infarct volume was around 125 ml. So technically, he was not a good candidate for thrombectomy, but clinically, he was not very bad. And he had a mismatch of about 120 ml. His infarct volume was around 200 ml, and that is the penumbra volume was around 200 ml. So there was significant mismatch. So I decided we should give a try to do mechanical thrombectomy. So this was his angio, his DSA. There was a complete occlusion of the ICA and MCA. So I did Solumbra in this patient. So this was a suction catheter. I don't know if you can appreciate. And this is how his, one more important thing is that this is how his angio was. So he has an ICA occlusion, but if you can see, there was a good flow into the subcortical area. So these are good patients actually. So he's clinically behaving as a distal MC occlusion because his basal ganglia and internal capsule area, his perforators were having a good blood flow. So I thought this patient probably will do well. And we did a Solumbra technique. This was a suction catheter here, and a stent was deployed into the thrombus. And this was the clot which was removed from his carotid, and we achieved a complete recanalization in this patient. But as expected, since infarct was big, this was the pre-scan and this was the post, we could achieve a complete recanalization in this patient. But the infarct was big, and we can see some hemorrhagic transformation into the infarct. However, probably his motor strip was preserved, and this was his on day 2, his power was better. And this was his gait when we discharged him from the hospital. So mechanical thrombectomy definitely works, and we all know that the AHA wants that more and more mechanical thrombectomy should be done in the year 2020 because it definitely helps the patients. Now, I'm not going to the tandem lesion, and we should, since in India most of the patients are not covered, they pay from their pocket and it's an expensive treatment. So we have to be very choosy about the treatment. We can't offer now. So we look at the aspects. We look at the NIHs. However, as the recent studies have said that probably we should offer mechanical thrombectomy to all the patients because we really don't know which patients are going to improve, even if the NIHs or aspects is bad. But for the time being, the patients whose aspects is good and who have major vessel occlusion with bad NIHs should be definitely offered mechanical thrombectomy. Thank you.
Thank you, Doctor. With all those practical examples, I hope the students, the PGs, have got a hang of the suction as well as the retriever and some other procedures. Let's move on to the last lecture of the day, obviously on cortical venous sinus thrombosis by Dr. Sridharan. I request her to start her lecture.
Am I audible? Hello.
Yes, you are. Yes.
Yes.
Yeah.
Yeah. Good evening. And after exhaustive 3 lectures on ischemic stroke and its management, I think this is just cherry on the top. Cerebral venous sinus thrombosis. I'll be discussing briefly on the etiology, clinical features, and management. So I will cover through the topic the background, etiopathogenesis, clinical presentation, investigations, management, which includes both acute and long-term management, and cerebral venous thrombosis in special situation before concluding with the recent advances in the topic. So we know that CVT is a cerebrovascular disease that presents with focal cerebral edema, venous infarction, hemorrhage, seizures, and intracranial hypertension as its most prominent clinical features. Unlike ischemic stroke, it often affects younger adults, women of childbearing age, and children, especially in the neonates. It is a rare condition, and the incidence is reported to be around 1.3 to 1.57 per 100,000 person years. And if diagnosed and treated early, it is generally associated with a good prognosis. So this is a list of the common etiological factors implicated in CVT, which I've taken from an NEJM article in 2005. Broadly, we can divide it into genetic and acquired prothrombotic states. The genetic prothrombotic states, antithrombin 3 deficiency, protein C protein deficiency, factor V Leiden mutation, prothrombin gene mutation, hyperhomocystinemia. Acquired prothrombotic states, which are vast. The important ones in clinical practice being APLA syndromes, primary or secondary, nephrotic syndrome, homocystinemia, then physiological states like pregnancy and puerperium, infectious causes of CVT, especially medullary infections, sinusitis, meningitis, systemic infectious disease, connective tissue diseases like SLE, vaginous, sarcoid, inflammatory bowel disease, Behçet's, hematological conditions, myeloproliferative disorders, malignancies. Then medications, there is a big list, the most prominent being oral contraceptive pills, especially estrogen-containing medications, L-asparaginase. Then following trauma, which can be head injury or neurosurgical procedures or even post-lumbar puncture. And in children, especially neonates, dehydration is an important cause of cerebral venous thrombosis. So coming to the clinical presentation, before going to the clinical presentation, one should know which are the sites which are commonly affected, because the clinical presentation varies depending upon the site involved. The most important sinus which is commonly affected is the transverse sinus. This is a picture which I have taken from the International Study on Cerebral Vein and Dural Sinus Thrombosis, that is ISCVT study, where the commonest site involved was found to be transverse sinus, followed by superior sagittal sinus. The internal deep cerebral venous system is involved in around 11 to 12% of patients. Veins alone may be involved in a small percentage. And if cortical veins are involved, then it can produce venous infarction, hemorrhage, and focal edema, which can be due to cytotoxic edema or vasogenic edema. Whereas if dural sinuses are involved, patient can present with intracranial hypertension. Most often we see that multiple veins and venous sinuses are involved in over 70% of patients. And 80% of patients have an acute presentation presenting within 7 days. So coming to the clinical presentation, the most common symptom with which patient presents is a headache, which is seen in 80 to 90% of cases. The classical description of thunderclap headache is seen in only 5 to 13%. In many patients, they may have a exacerbation of the past history of migraine or an unusual headache in their life, which builds up over hours to days. Then some patients can have a cluster type of headache as a presentation. Then post-LP intracranial hypotension related headache also can be a type of presentation CVT. Headache may be the only presentation in 14 to 40% of patients with cerebral venous thrombosis. Another important presentation of cerebral venous thrombosis is seizures. Early symptomatic seizures, which is usually seizure occurring within 2 weeks of illness. The important predisposing factors of seizures are presence of hemorrhage, supratentorial involvement, altered sensorium. All these predicts high seizure risk. Another important form of presentation is the focal neurological deficits, which can be motor deficit, aphasia. Patients can present with cranial neuropathies, especially the cavernous sinus thrombosis patients can present with external ophthalmoparesis. Then transverse sinus thrombosis, they can present with lower cranial nerve involvement. Altered sensorium can be due to large hemispheric lesions, raised ICP, deep cerebral venous sinus involvement, or secondary to seizures. When to suspect CVT? If a young or middle-aged patient presents with recent onset unusual headache or with stroke-like symptoms in the absence of usual vascular risk factors, and also if patient presents with raised ICP features, one has to suspect cerebral venous thrombosis. And if imaging shows hemorrhagic infarcts, especially infarcts are multiple and not confined to any arterial territory, one has to strongly suspect a cerebral venous thrombosis. Most of the studies, including the ISCVT study, have shown that the average delay from onset of symptoms to the diagnosis is around 7 days. Coming to the investigations, the mainstay of diagnosing CVT is neuroimaging. MR venogram is the initial investigation of choice. Why MRI is preferred over CT is because one can get an extent of parenchymal involvement with MR imaging. Then also the thrombus can be seen in the MRI, and the stage of thrombus, whether it is a hyperacute, acute versus chronic, can be made out using a plain MRI itself. And another advantage is we can do a venogram without giving contrast, which will give added information about the condition. If MR venogram is not easily accessible, then one can go ahead with a CT venography. The studies have shown that it has a sensitivity approaching 75 to 100% in comparison with MR venogram in diagnosing a venous thrombosis, with the advantage being rapid image acquisition, especially in unstable patients. Only rarely conventional angiogram is required for confirming the diagnosis. Another investigation is often done in the setting of suspected cerebral venous thrombosis is D-dimer. D-dimer, as we know, has a very high sensitivity and specificity in predicting venous thrombosis, including cerebral venous thrombosis, the order of over 95%. It has got an excellent negative predictive value in diagnosing CVT. That is, if the D-dimer level is not elevated, then one can reasonably rule out cerebral venous thrombosis, especially acute cerebral venous thrombosis. And European Society Stroke Organization recommends performing D-dimer in patients with isolated headache more than 7 days if CVT is suspected before imaging. Then other investigations which should be done in all patients with cerebral venous thrombosis. One is tailored at the etiology, which includes both hereditary and acquired procoagulant causes. Then screening for infectious causes for CVT, especially sinusitis, meningitis, and also screening for malignancies. Coming to the management, acute phase, anticoagulation, heparin is a mainstay of treatment. We know that there is a strong evidence in favor of heparin over placebo in improving the outcome in CVT. And one has to be aware that it should be started even in the presence of a hemorrhagic infarct or hematoma. About the type of heparin, there is weak evidence in favor of low molecular heparin over unfractionated heparin, except when low molecular heparin is contraindicated, and also one is anticipating a need for a neurosurgical procedure, especially if a patient has got a very large hematoma or a large infarct with a significant mass effect, and we are suspecting that the patient may require decompressive hemicranectomy, then it is always safe to start unfractionated heparin in the initial phase as an infusion, so that if a surgery is required, we can immediately reverse the action of heparin. Coming to the role of thrombolytic therapy. Unlike arterial stroke, where there is enough and more evidence now that mechanical thrombectomy and thrombolytic therapy are the gold standards of treatment in patients coming within the window period. In cerebral venous thrombosis, the evidence have been scanty. So this large trial, recent trial, which has addressed the utility of thrombolysis versus anticoagulation for cerebral venous sinus thrombosis. That is 2-act trial, just published this year. They're adult patients with radiologically confirmed CVT who had at least one risk factor for a poor outcome, like altered mental status or coma, in presence of a large intracerebral hemorrhage or thrombosis of deep. They were randomized to receive either endovascular treatment with standard medical care, that is heparin, or a guideline-based standard medical care alone. The study, however, showed that EVT arm did not appear to improve the functional outcome of patients with CVT in comparison to the standard medical care. Now, what is the role of decompressive hemicranectomy, unlike arterial strokes? There are no randomized data on the utility of decompressive hemicranectomy in cerebral venous thrombosis. However, multicenter studies, including the second ISCVT study, have shown that patients with large parenchymal lesions causing herniation, decompressive surgery is life-saving, often results in a good functional outcome, even in patients with severe clinical conditions. Then coming to the other medications which should be given or which are indicated in the acute setting, one is anti-epileptics. The anti-epileptic here, there is a role for anti-epileptic as even primary prophylaxis, especially in patients with the intracerebral hemorrhage or with the supratentorial lesions, because seizures can worsen cerebral edema and portend a poorer prognosis. Then in pseudo IIH like presentation of CVT, which about 25% patients present with, patients should be treated with inhibitors, which like IIH has a better role in improving their visual outcome. Steroids are indicated if there is an underlying systemic vasculitic disease like SLE or Sjogren's, where the underlying vasculitic disease also has to be tackled along with the thrombosis. Now coming to the long-term management. After patient is stable, patient should be initiated on oral anticoagulation. The conventional treating is vitamin K antagonist. However, there is increasing evidence in favor of NOACs in venous thrombosis and especially cerebral venous thrombosis as well. One of the studies, the RESPECT CVT study, which was published last year, where dabigatran was compared with warfarin in cerebral venous thrombosis patients. It was found that patients who had CVT, on either arm fared well. They had very low risk of recurrent venous thrombosis, and the risk of bleeding was similar with both medications. Now coming to the duration of treatment. In patients with transient or no overt thrombophilic conditions, the usual duration of anticoagulation mentioned is 3 to 6 months. Whereas if there is a high-risk thrombophilic condition like an APLA syndrome or protein C or protein S deficiency, then often the anticoagulation given is lifelong. And these questions are now being explored in large studies like EXCOA CVT study, where a long term, that is 6 months to 1 year anticoagulation is being compared against short-term anticoagulation. Coming to the prognosis, more than 80% of patients have an excellent outcome in cerebral venous thrombosis. Which are the poor outcome predictors? Older age, male gender, presentation with the altered sensorium, deep venous system involvement, hemorrhage on admission CT, associated CNS infections and cancer are poor predictors of CVT. Now coming to special situation, pregnancy associated cerebral venous thrombosis. We know that there's a higher risk for developing venous thrombosis, including cerebral venous thrombosis in pregnancy and early postpartum period, that is in the first 6 weeks postpartum. A patient developing venous thrombosis during this period should be treated with either unfractionated low molecular weight heparin during pregnancy, and it should be continued for 6 weeks postpartum. Warfarin can be continued in the postpartum period, and regarding NOACs, there are no data. Hormonal contraceptives, especially estrogen containing contraceptives, should be avoided in patients who have a history of cerebral venous thrombosis. This is as per European Stroke Association guidelines on CVT published in 2017. And subsequent pregnancies also should be covered with therapeutic anticoagulation. Now, before concluding, a small note about COVID and CVT. We know that like arterial strokes and hemorrhage, few CVT cases also have been reported along with COVID-19. It has been found that the 1/3 of the patients can have deep venous system involvement in this case series, and the patients were treated with anticoagulation. But the observation found across these case series was that it is associated with higher mortality than the usual CVT. Just concluding with the recent advances, the recent trials which will be of use. One is the RESPECT CVT study, which was published in 2019, where the role of warfarin against dabigatran was explored in cerebral venous thrombosis. It was found that both these fared similarly in reducing the recurrence of venous thrombosis, and the bleeding risk was also comparable between the two groups. Then another is the NOACs study, which I've already mentioned, endovascular therapy with conventional medical management versus conventional anticoagulation in the acute phase of CVT. In this study, it was found that conventional anticoagulation was not inferior, or the endovascular therapy was not superior to anticoagulation in the acute phase of CVT. And these are a few references for future reading. Thank you.
That was pretty thorough. Just one question, ma'am, about the dose of unfractionated heparin for venous sinus thrombosis. That is the question. So,
unfractionated heparin, the target is maintaining APTT 2 to 2.5 times the upper limit of normal. So usually 5,000 units bolus followed by an infusion of 800 to 1,000 units per hour, titrating with the APTT values. And regarding the low molecular heparin, it is 0.1 unit per kilogram body weight.
absolutely, absolutely. I think many other questions have already been answered by speakers after their lectures. I think it was a very, I suppose, a large thing today. So many points covered in each of the lecture. I hope our PGs pick up on all of them, right from triage and this thing, transportation of stroke patient to taking him to the cath lab and clot retrievals, also so much on radiology. So let's hope it has been very useful. I welcome all my speakers to give some guidelines to the PGs preparing for exam. Vivek? Vinit?
Yeah.
I'm the third and will just
I'm so the only way to vote is like be confident.
absolutely. I think what I
Limit
feel is
yourself to learning for
stroke is one
exams
area.
because life has a
Yes, I think stroke is one of the,
yeah.
like everybody has quoted certain trials. Some of the trials I would say the PGs should remember and be able to quote, such as, for example, Vivek quoted Chance and Point trial. Dr. Oak has quoted trials like MR Clean and Swift Prime Revascat for the first 6 hours, and then the Diffuse and Dawn trial for 16 and 24. So there are some cardinal, like Madam has also quoted certain trials in relation to dabigatran. So I personally feel there are some pioneer trials in diseases like stroke and also maybe in epilepsy and multiple sclerosis, which they should know, they should remember their objectives and their outcomes and a little bit on the structure of trial. And they should be able to write in their exams or also quote if they're asked while presenting their case. That's what I thought. And I think all of you have beautifully brought them in. I think Madhusudan sir was there, but I think he has left. Anything else you guys want to say? Sagar? Yes, Pradyumna?
Yeah, hi. So basically, I passed out in 2002, and when we were doing our DM, we were not exposed to clinical stroke at all. We learned our stroke after passing. We learned our
Absolutely.
stroke in our practice. So I urge all the residents that this is the time for you to learn. This is the time for you to commit mistakes. So see acute stroke patients, be a part of the treatment of acute stroke patients when you are doing your residency, because that will only increase your confidence. So I think that's the most important thing you guys should do.
Absolutely. Absolutely.
I think for
Can
exams,
I?
for exam, Sapna, 1 minute. For exams, I think whatever we work in the unit for stroke would be very useful. And the rest of things are all flow charts and diagrams and tables. I think we know how these examiners are examining the theory paper. They just go through, brief through the paper and see how are the charts and how are the points. Now, I think we will make more number of charts and tables so that, all the points, and I think whatever you remember exactly is what you do during the residency rather than
Absolutely.
reading. So I think stroke is, so you involve more in the stroke unit, like take the patient to cath lab, be with the intervention guy, see the things and see the hardware and all those things you remember rather than, we learn a lot and then writing. Then trials, of course, we would have a few discussions about trials and remember the trials, and, that will add a very much value to your paper, because the examiner will just go through and see that these things are written. I think definitely he will prefer that answer paper rather than it is not there.
Absolutely. Ma'am?
Yeah.
So,
I also share what Vivek said. You should have your subheadings right. Like even if the content is not too much, if you have all the subheadings in place with some colors, definitely we know that examiners, they will be looking at your theory paper in between the practicals. They don't take too much time to value the paper.
Yes.
So if you have your subheadings right, all the subheadings in place, and some of the new advances also as a table, then definitely you will be scoring 7 or 6 or 7 out of 10 without any problem. And acute stroke, we all know that more than 50% of the patients you're going to see after you pass out from your DM is stroke itself. So you have, even if the examiners don't ask you much, you have to know everything A to Z for the practical purpose.
Absolutely. Perfect. Good. I think very useful session. Later on, you all are going to help me share those in the form of PDF. Let's hope all of them find them useful. Thank you very much, all of you. You worked tirelessly for this relatively difficult and day-to-day scenario. Thank you. Thank you. Good night.
Yeah.
All of you.